Hopefully she didn't go too far. She's coming back up, and she's going to talk to you about biomarkers.
Thanks. All right, I know I'm between you and lunch, so I will be fast. All right, these are my disclosures. All right, so biomarkers. Biomarkers are characteristics that you can measure in the body, and so it's not an outcome like I don't have any verbal communication skills or I have limited mobility. Biomarkers are objective measures that we can measure, and in Angelman syndrome we look at CSF, EEG, and MRI. These are some of the biomarkers that we're interested in because they're relevant to individuals with Angelman syndrome. On the right here, what you'll see is essentially FDA's roadmap of what biomarkers can do. They can be diagnostic, so it could be a gene test for a diagnosis of a disease. They could be for safety reasons, so maybe you have an antibody at baseline, and if you were going to get a specific treatment, maybe that's not safe for you. But what ABOM is really focused on are biomarkers that predict response or indicate a response to a treatment, which are efficacy biomarkers, or sometimes you might hear them referred to as surrogate endpoints. So this is kind of what we've been looking at as the ABOM. So first you have to understand, what is an endpoint? So an endpoint is something that you measure in a clinical trial. It's a targeted outcome in a clinical trial that you analyze statistically to determine if a drug is safe and effective. And the way that we do that is we include outcomes that are relevant to the disorder. So in Angelman syndrome, it could be communication, sleep, activities of daily living, and whatnot. These are outcomes. And then you pick an outcome and say, I'm going to look at the change in this outcome from pre-treatment to after treatment to determine if there was a response. Usually an outcome measure focuses on a way a patient feels or functions. So when I mentioned communication, that would be sort of how a patient is functioning, or an individual with Angelman syndrome that has limited speech capabilities or communication capabilities. We might look at that as an outcome in terms of how they are functioning. And importantly, outcome measures should be relevant to the disorder. It seems obvious, but they really need to be relevant and ideally capturing what matters to you, which I just mentioned in the prior presentation. On the bottom here, this graph is the top 10 treatment priorities as determined by the PFDD survey. It's in the Voice of the Patient report. And so what we're trying to do is make sure we have outcomes that capture symptoms that you rank as important. So for example, we wouldn't want to do a study that's focused on pain if you say, I don't care about pain or how much pain my child has. What I care about is, do they communicate more effectively? Do they understand me better? Biomarkers can sometimes also be endpoints in clinical trials. And this is what I mentioned before as a surrogate endpoint. And that's a biomarker like measuring blood or CSF that's thought to predict clinical benefit, and meaning that you're not measuring how a patient feels or functions through the biomarker, but you think that there's a relationship between that biomarker and an outcome measure so that the biomarker will predict a change in that outcome measure later. And oftentimes you use biomarkers as surrogate endpoints in disorders when it takes a really long time to measure that outcome. And so an example of this would be in a study maybe where you were looking at people with cardiovascular diseases and you were trying to see if a drug changes the number of strokes that happen in a population. And so if you enrolled a group of individuals that had risk factors for stroke, if you had to follow them until they all had or didn't have a stroke, you might be following them for a very, very long time. And so usually what happens instead is they focus on other measures or biomarkers like blood pressure and say, okay, if I give this patient a drug, and do I make their blood pressure go down? And then you can get an approval off of that biomarker instead of waiting all the way to see the outcome. But to do this, you have to accumulate extensive evidence, and I want to say extensive evidence because from a regulatory perspective, FDA and other agencies will really want you to show that you really know how the biomarker does relate to that outcome. And usually you need clinical trials to do that, to really prove the relationship between that biomarker or surrogate endpoint and the clinical outcome that you think will be changed. So If we think now about Angelman syndrome, some of the biomarkers that we believe are important and have investigated as the ABOM are EEG, MRI, and CSF markers. So I'll start with EEG. So here, you may have heard in some forums, delta power is measured. So it's a parameter on EEG that we see is increased during sleep and wake periods in individuals with Angelman syndrome. And if you start on the left, you will see in that plot, there's a red line and a gray line, and the red is Angelman syndrome, and the gray is a neurotypical or a group of neurotypical individuals. And you can see that this delta band is increased clearly in individuals with Angelman syndrome. We also know that this delta band or delta power decreases over time with age, just naturally. But if you look in the middle plot, you'll see the red is still higher than the gray. So it's still higher in individuals with Angelman syndrome than it is in neurotypical individuals. And this increased delta power is really thought to be due to the lack of UBE3A that impacts synaptic functioning. And you heard about both UBE3A and some of its effects this morning. If you look on all the way to the right, we see that in individuals with deletion mutations or non-deletion mutations, it's a little bit higher in individuals with deletion, which might accord to the fact that deletion is usually the most severe presentation of Angelman syndrome. And so it's very much increased, and there's a little bit of a difference even between mutation types. I'm not going to explain all of what's in this plot, but essentially it's safe to say that there's been some ABOM groups, or some ABOM members, I should say, that have investigated how delta power might relate to outcomes in Angelman syndrome. And what they've seen through data and analyses of the natural history is that the higher your delta power is, the lower your cognitive function would be predicted to be. So they can see in individuals with high delta power, their cognitive abilities are lower. And so that's how that relationship might unfold, that if we bring delta power down, maybe some abilities would grow. Importantly, we know that the mouse, the Angelman mouse that you heard about this morning, also has this delta power increase. And there have been studies by some of the groups involved in ABOM that have looked at using an oligonucleotide in a mouse. And if you look at the blue group here, they took mice and they gave them an antisense oligonucleotide that targeted that paternal gene, antisense transcript, to try to unsilence the paternal gene and allow UBE3 expression. And so when they treated these mice, the blue group, and they compared them to mice treated with a control oligonucleotide, so either Angelman mice on the left, or in green, wild type or typical mice, they saw that they were able to bring the delta power down in the mice that were treated with the antisense oligonucleotide that was specific for Angelman syndrome, whereas the mice that got the control ASO that had Angelman syndrome didn't change at all. So they saw with treatment, they could bring down this delta power. Most importantly is now through clinical trials, evidence is emerging that you can do the same in humans. And what they've seen in the red here versus the blue, the red is the natural history data predictions. So again, the power of natural history data, because we can compare delta power in untreated individuals versus treated. So red is the natural history prediction, and blue is the treated group on an oligonucleotide. And you can see that their delta power is coming down. And importantly, on the right, you could see this group also had an increase in their cognition abilities based on an assessment by the Bayley scale. And so it sort of is following that predicted trend that if you improve their delta power, you bring it down with treatment, you might see a change in outcomes. We're also looking at MRI as a potential biomarker. We know very little about this. What we do know, as Allison mentioned in her talk, is that individuals with Angelman syndrome have delayed myelination. And so what you're looking at here is a plot of individuals, males and females with AS, in the circles, those sort of blue and pinkish circles, as compared to the triangles, which are a neurotypical population. And you can kind of see that on average, the brain size is a little bit less in those younger individuals with Angelman syndrome. If we could use MRI, that might be a nice way to see if that changes with treatment and if they catch up in that myelination and then that brain volume. So that's something that we're going to follow further to explore and look at. And then we look at fluids. You heard that in Allison's talk, and this is something we saw yesterday. We had some really interesting talks at the ABOM on biomarkers yesterday, and one of them was about a test that's run by a company called Scapa, and you're going to hear Morty talk later today about this in more detail. But what they've done is take cerebrospinal fluid, or CSF, from individuals with Angelman syndrome and also neurotypicals to see if there is a difference in their UBE3A expression. So can you see if there's protein, that UBE3A protein, in neurotypical individuals, and then it's missing in individuals with Angelman syndrome? And that's in fact what they've started to see on this test. And I'll let Morty talk about that more in his talk. But this is very important from a regulatory perspective, because if we could measure UBE3A, so if there was none before treatment, and then you see it go up after treatment, that would be an indicator of response to a therapy that we could see earlier, maybe than some of the outcomes on the clinical measures like the Bailey or the ORCA or the Vineland, right? It would give us really early evidence and powerful evidence of a change, because you wouldn't expect it to be there. That's the left-hand side. On the right-hand side, we also have a company called SomaLogic that's doing some exploration into proteins in the CSF. And this is a busy plot, but if you basically look at that bottom box in red, where you see some pink and reds, what we've started to see is there's some protein signatures that's a little bit different in individuals with Angelman syndrome than neurotypicals. And so we need to further explore what those signatures mean, and do they correlate to outcomes. That we don't know yet. So, based on what we know about EEG and CSF and MRI, the question is, are these biomarkers surrogate endpoints yet? Can we use these in trials and make that sort of the primary focus, and look at the outcomes later to maybe speed up our clinical trials and readouts? Unfortunately, no, we're not there yet. We're just not there yet. We need to know more, and your data contributions and the samples that you've provided help us explore this further. And it's not something we're going to give up on, but we're just not there yet. We need to build more evidence to do this. And what I'm showing here are the 2 phase 3 trials that are ongoing now with Ultragenyx and Ionis. And you can see their primary outcome measures are on the Bailey scale, some aspect of the Bailey scale. And that's because we're not there yet with those other measures, including delta power, to utilize that as the primary focus of the trial. This is a busy slide, but what I want to show you here is that biomarkers are powerful even if they're not ready to be a surrogate endpoint. And that's because they provide really good objective evidence that rounds out your whole data set, and they can support outcome measures. And I like to think of it as a belt and suspenders in your clinical trial. Tofersen is a drug that was approved a few years ago for ALS, and in the top 2 boxes here, I think I have a build. What I wanted to show you is that they did a pivotal trial, so a phase 3 trial in individuals with ALS, and they used a rating scale that's assessed by a doctor to look at whether or not their symptoms of ALS are improving. So sometimes when you have these scales, you can have variability from doctor to doctor in how they assess it. Even if you really try to train them up and make sure there's consistency, there's a little bit of variability, and so sometimes that impacts the analysis. And what happened in this study was that they failed. They did not hit that primary endpoint. It was not successful. But they had studied a biomarker called NFL, or neurofilament light chain, and there'd been a lot of work to understand what does this mean in ALS, and it's basically a marker of neurons degenerating. And they understood that it related to the progression of ALS, and this was part of the trial. And so even though they failed the primary outcome, the FDA said, well, you know, we've learned a lot about NFL, and what we see in your data set, what you're showing us is that in patients that have a reduction in NFL, they also have like the best reduction in their ALS rating score. So there's some sort of relationship there with bringing down this biomarker and improvement, even if you failed the primary endpoint. And so even though you didn't hit what you were supposed to hit, when we look at the total package of evidence, we think that there's something there, and we're going to approve this, basically, on this surrogate endpoint. Even though that's not where you started, that's where you're going to end up, because this evidence was persuasive, and we feel like biologically something's going on. And that's what good biomarkers can do. They sort of build up and provide evidence that something is happening at a biological level, even if some of the outcome measures don't really show that yet. The other thing that biomarkers do are they can revolutionize the landscape of development. And this is because sometimes you can read out these biomarkers very early. And I'm showing you here a paper about multiple sclerosis, and they had a real explosion in that area because they had advancements in MRI technologies, and they started to have better confidence that they could measure the lesions on the brain that are involved in MS and predict how that would relate to how the patient felt and functioned in terms of like their relapse activity. And so what they did was they built this data set of correlating number of lesions to activity in patients, and they could basically start to see that if we treat patients with the drug and we see these lesions go away, then we have good confidence and good evidence here that shows that they won't have as much activity, they won't relapse as much and have as much loss of function and feel bad. And what this did was absolutely explode that area, because companies could come in and say, I'm gonna do a short study and I'm gonna look at MRI over 3 months, and I'm gonna know whether this drug works or doesn't. And if it works, I'm gonna put money into developing it. And if it doesn't, we're gonna move on to something else. And this area has, I think, over 20 approved therapies. I can't even count how many therapies there are approved for MS. But that biomarker absolutely moved that landscape. And that's basically what we wanna do here. Even if these biomarkers aren't providing us what we want for today, we want to invest in them for tomorrow, because we may get to a point where we can screen candidates earlier and quickly, make those good ones advance, and move away from things that don't. And I just want to end by thanking you for your contributions, especially with biomarkers, because they're not easy to get. Thank you so much, because you are absolutely enriching and informing the development landscape. Thanks.
Okay, I'm the only thing standing between you and lunch, I understand that. So we're gonna get you there. One thing I wanna just announce is a couple of items were left at the community event last night. So out at registration, there's like shoes and maybe even a purse and scarves and things. Please go out to the registration desk to go and get that. In addition, the sign up to meet with a specialist. So just so everyone knows, we have here some unbelievable and highly experienced specialists in PT, OT, speech therapy, ABA therapy, vision therapy, neurofeedback, and feeding and swallowing therapy. And you, for free, families can sign up and have a consultation with them. There's the Meet the Specialist sign up. If you walk out the door and go to the left, there's Bianca is gonna be waiting there, and anybody can sign up, and there's still some slots left. And take advantage of this, because all of these individuals have worked deeply with children with Angelman syndrome and adults, and have been incredibly supportive of helping families get through whatever challenges they're having and give them some advice. So please go out there and sign up. If everyone wants to break for lunch, we're gonna meet back in here with your food for a lunch and learn. So Ryan's gonna talk to us about advocacy, but you're welcome to bring your food back in and eat and listen at 1:20. So go out, have yourself some food, bring it back in here. Everyone eat in here so Ryan can get started while you're eating at 1:20. We'll see you soon.